Sir.
Yes, sir.
So today we will study about a condition called as pelvic fractures. I will give you basic fundamental things that you have to remember as a general practitioner. Yeah, what you have to remember, I will give you the keynotes. What things will be the outline? See. So what things, like as you prepare for any trauma class, some people already finished their cycle, some people still have their cycles on the way to go in the coming weeks. So if you study any trauma in any segment of the body, yeah. So first of all, first thing you should open anatomy book to know the parts of the bones. You should know the bones. Understand, doctor? So you should open the anatomy atlas and study the bones in detail, their parts. You will be a very good student if you didn't just stop by studying the bones, but you study a little bit of attachments. Yeah, so in the bones attaches different muscles. Yeah, if you study those things, you are excellent student already. Yeah, little bit more very excellent is if you know what innervates, yeah, what artery innervates, what artery nourishes the muscle, yeah, what nerve innervates the region. If you study, that is perfect actually. So you can understand this thing in a very good way. But fundamental is you should at least know names of the bones. Understand, doctor? After you know this thing, second point that you should study is mechanism of injury. Any trauma from the first lecture that we discussed, there is two mechanism. It can be direct, that means direct blow on the bone fractured. Indirect, indirect. For an example, twisting force happened in my hand. Maybe I have dislocation of my shoulder. You understand? So force act in a place. And what happened? It is being transferred, and distance away, I have a fracture. This is an indirect mechanism. So you should know the mechanism of injury. Third point that you should know is classification. I gave you in the first lecture. Please go back and refer the first two lectures. Yeah, it is always there in the Moodle. Yeah, please refer and study once again. I gave you how to formulate diagnosis for fracture. Yeah, so that is very simple basics. Most of the fractures are classified on that basis. So that is a fundamental method. So you should know the classification. Little bit, it is good. At least fundamental classification, you should know. The third thing you should know is, next thing that you should know is clinical picture. Yeah. So in the first and second lecture, we talked about general signs and specific signs. They are simple to remember. You should memorize them. There is no other way if you don't memorize. In this 10 signs, you should see what sign is characteristic for this fracture, or some other clinical signs are added, something specially is present or not. Should know. This is the fourth important point that you should remember in this thing. Next, you should know first medical aid for this concrete condition. Any condition, yeah, you should know first medical aid. After you know first medical aid, you will go for treatment. Actually, the patient is brought to the hospital. How to treat conservatively, how to treat operatively. Yeah, so these ones are given in your Moodle links. Yeah, so we have AO surgery reference. Yeah, up to date treatments are available for different localization, yeah, with videos. Yeah, so we gave the link for you. Yeah, you can keep yourself updated, and that link can help for your life as you practice in the field of medicine and refer. When we give treatment, the final thing you should think about is how long the fracture will consolidate. What is the duration for consolidation of the fracture? So we started from clavicle. We know clavicle consolidates into 3 to 4 weeks time. When we went to humerus, maybe it is a bigger bone. It consolidates in maybe around 6 to 8 weeks time. Yeah, so maybe in the femur it will be 8 to 12 weeks time. So different bone has their own average time for consolidation. So we should know. So until this time we should immobilize, or there can be some restriction to the patient, because then only the bones will consolidate. Understand, doctor? And think about physiotherapy. Yeah? Some people are telling they have polyclinic therapy, yeah, where you study in detail about different physiotherapeutic measures. Please pay attention in trauma-related physiotherapy plus exercise therapies. Yeah, different exercise therapies are there. Yeah. So please pay attention to it. So this is an outline. So until this point, do you have any questions? Do you have any questions on the outline? How to prepare for
No,
any
sir.
class? Okay. So let's continue. Yeah. So if you talk about clavicle, one more thing that we'll be studying a little bit of statistics. Yeah. So about the bone, You understand hip bone is a ring-like structure, right? It is a circular, is a ring-like structure, yeah. So pelvic hip bone, two hip bones, and then what happened? They are connected anteriorly by one structure. Posteriorly, we have continuation of our vertebra, yeah. Sacrum is available, yeah. If you take the hip bone, it is composed of three bones, ilium, ischium, and pubic. And if you talk about this hip bone, connected to the sacrum, yeah, vertebra with the help of a strong ligament, anterior, posterior, or sacroiliac ligament. It is a very strong ligament. It cannot be easily broken, torn, yeah. And anteriorly, so when we talk about where these three bones are fused, ilium, ischium, and pubic bones, they are fused in the acetabulum. Yeah, it forms like a socket, yeah, where head of the femur articulate and forms the hip joint actually, yeah. So when we talk about frequency of damage, yeah, so here we have a short statistics about frequency of injury to hip in different region. So 25% of pelvic fracture will have what? Multiple injuries. The patient will have multiple injuries. 50% with pelvic fracture, there can be damage to the pelvic ring. So we'll discuss what is pelvic ring and what a traumatic shock develops in every third patient. So you should know already, yeah. So patient develops shock, yeah. So you should take what up an anti-shock measure. It is a part of first aid. When you do first medical aid, you should do preventive measures to stop the progression of shock. So this thing you should know actually. Next, what are all the problems in this topic that we have? What are the problems? When we talk about bleeding from upper limb or lower limb, we actually can orientate where the bleeding would have happened. Yeah, so it can be from brachial artery in upper limb, brachial, radial, ulnar artery, maybe, yeah, or femoral artery, yeah, anterior, tibial, posterior artery. We can differentiate in the lower limb, yeah. But when we talk about pelvic region, yeah, so here there is very big vessels plus very strong anastomosis, and we can't differentiate from where the bleeding has initiated. Yeah, is it bleeding from an intrapelvic organ or it is a bleeding from concretely from artery? So we don't know. Next is what happened. Biggest problem that we have is what happened. How to stop the bleeding. Next, one more problem that can come across to us is how to stabilize the pelvis. These are all the biggest problems that is put forth in front of a doctor when you handle the pelvic fracture. Yeah. Next thing. Let's continue here to talk about a little bit of anatomy, and let's see how is your knowledge in anatomy. Yeah? So here we have the hip bone. Yeah, this is our hip bone actually being demonstrated actually. Yeah. So how do you call this structure? How do you call this structure? How do you call this structure? How do you call it? Iliac crest we have. Yeah. So you know this is your iliac bone. Yeah. And this part of the iliac bone, how do you call this part of the iliac bone? How do you call this part of the iliac bone? How do you call this part, the circular part of the iliac bone? How do you call it?
Wing of the iliac bone.
Very good. This is actually wing of the iliac bone. But in the wing of the iliac bone, anteriorly we have this thing. How do you call that? It's a wing of the iliac bone. Actually, it is a wing of the iliac bone. But in the wing of the iliac bone, this structure, how do you call it?
Iliac fossa.
Very good. This is iliac fossa. Okay, doctor. So in the anterior aspect of the wing of the iliac bone, we have iliac fossa. Plus the iliac bone has some very prominent bony prominence. How do you call this structure? How do you call it?
Anterior superior iliac spine.
So this is a very important anatomical structure. Yeah, so not just used in trauma. Yeah, but you can see it is widely used in obs and gynecology. Yeah, when you do pelvimetry. Yeah, so anterior superior iliac spine, it can be palpated in any patient. Yeah, it has a lot of clinical significance. So if this is going to be anterior superior, how do you call this?
Anterior inferior.
The anterior inferior iliac spine. In the same way, posteriorly, yeah, if you see here somewhere in this region, there will be posterior superior and posterior inferior. Yeah. So how do you call this one? This one?
Acetabulum.
Acetabulum, yeah. Here is where what happened, all these three bones fuses, yeah. So here is where your three bone fuses. That is, you can see here, this is from the iliac bone, this is from the pubic bone, this is from the ischial bone, yeah. So these three bones are fused in this region called as acetabulum. So so this is your pubic bone, yeah. So this whole thing is your pubic bone. How do you call this part of the pubic bone? This and this part of the pubic bone. How do you call this and this part of the pubic bone?
Ramus of
Yeah, so we have superior pubic ramus and we have inferior pubic ramus. Yeah, how do you call this one? How do you call this structure? This is called body of the pubic bone. This is body of the pubic bone. Yeah, so this is ischial tuberosity. Yeah, ischial bone. We have ischial tuberosity is present here. Then we have what? Two pubic bones are connected to the help of what?
symphysis.
Symphysis pubis, it is a cartilage. So here this is a cartilaginous structure, yeah. But anterior and sacrum and iliac bone, they are connected to the help of a very strong ligament. We call it as anterior posterior sacroiliac ligament. It's a very strong ligament. So if two bones are connected with the help of ligament, how do you call it? If two bones joined by a ligament, how do you call this? It's called as what? Syn. How do you call them?
Symphysis pubis.
So it is called syndesmosis. Yeah. So sacroiliac joint is syndesmosis. Yeah. Here we have two bones. There is two pubic bone. They are connected with the help of symphysis pubis. So how do you call this connection? How it is called as syn? How do you call them, doctors? How do you call them? We call them as what? Synchondrosis. Understood? Hello? Understood?
Yes, sir.
Next, in this acetabulum, what happened? All these bones are fused with a bone with the help of suture. So it is called synostosis. We have them in acetabulum. Yeah, in acetabulum region, we have synostosis. So when we talk about synchondrosis, like two pubic bone, yeah, connected with the help of cartilage, synchondrosis, it can be of two variant, temporary or permanent. Yeah. So connection of two symphysis pubis, two pubic bone with the help of symphysis pubis, a permanent type of synchondrosis. Same like how we have sternum with the ribs. Yeah, they connected with the help of cartilage. Yeah, once again, it is a permanent type of what? Synchondrosis. We have temporary type, yeah, but when bone grows, yeah, when the bone is growing, yeah, between epiphysis, yeah, between phases, yeah, growth plate, we have bone above and bone below, yeah. So the growth plate is a cartilaginous structure, yeah. So this is a temporary type of what? Synchondrosis. So as we grow, what happens? This growth plate disappears and we have a concrete bone. So it becomes like growth plates in every bone. In children and all, when you see like proximally there is a bone, middle there is a bone, and then what happens? Growth plate, and distally there is a distal metaphysis present, yeah. The growth zone, yeah, divides two bone actually, yeah, but it is temporary type of what? Synchondrosis. When we become adult, it become already a concrete bone actually. But in acetabulum, what we have here, bones, like in the skull, we have what? Bones are connected to the help of what? Bone by sutures and things like that, yeah. So we call them as synostosis. Next, we have diarthrosis. A hip joint is an example of diarthrosis. Synonym is true joint, because why? We have acetabulum. Yeah, it's articulating cartilage. It articulates with head of the femur. Yeah, so head of the femur will articulate. Between them, there will be interarticulating space. Yeah, so there will be interarticulating space, and that the interarticulating space will be filled with. So here we have, for an example, yeah. So let's try to draw. So here we have acetabulum. Here we have head of the femur. Maybe yes. Simply we try to draw. Yeah. So in between them, there is interarticulating space. For sure, there is what? Joint capsule of the joint is present, yeah, and this area is filled with what? Synovial fluid, and this joint can move in all direction, yeah. So this is called synchondrosis, or other name it can be called as true joint. So almost different types, almost all types of joints we can find in the hip region. Next, so when we take the hip region, yeah, we can see what happened. You see very good So here we see branching of our abdominal aorta, yeah, to right and left side, yeah, and what happened? Internal organs are present over here, like urinary bladder and female reproductive organ, yeah, and what happened? Distal part of your intestine, larger intestine, yeah, sigmoid colon and rectum, yeah. So this is available over here, yeah, and we can see what happened. It has very big arteriovenous anastomosis present in this region, and we can see already in the lumbar region, yeah, lumbar plexus is start to form, yeah, and where it goes already your radial nerve, ulnar, sorry, femoral nerve and sciatic nerve to your lower limb and other accessory nerves that is innervating the internal organ actually. Yeah. So there is very good nerve supply, blood supply, and internal organs are present inside the pelvic cavity. So when there is a fracture, in the pelvic region, it will cause what happened? Bleeding. Yeah, bleeding is a very serious complication in pelvic fracture. The problem is we don't know the source of the bleeding, and it is difficult to stop this bleeding. So this question always stays in front of the doctor, how to handle this thing. So after we introduced about this topic, let's get into the mechanism of injury. So mechanism of injury can be direct or indirect. Yeah. So direct mechanism can be blow from the side that we can see over here. Yeah. So when you have blow from the side, maybe you can have fracture of iliac crest, or maybe blow from the side, maybe it can lead to fracture of acetabulum and central dislocation of head of the femur can happen. Or blow from the front, when patient had a blow on the front, what can happen? There can be, it can lead to fracture of what superior or inferior pubic ramus that we can see over here, yeah, and can lead to what happened? A condition something like this. So here in this concrete patient, there is fracture happened to superior, inferior pubic ramus on both sides, yeah. And when you take an X-ray, it looks like a butterfly, yeah, or in this case, pelvis will open like a book. We also call it as open book fracture. Or blow from the back, yeah, blow from the back can damage sacroiliac joint. Very hard to break sacrum, but sometimes maybe can be fracture of sacrum or sacroiliac joint can be happened actually. So this is direct mechanism of trauma. Any questions on direct mechanism of trauma? Any questions on direct mechanism? Next we have indirect mechanism. What is this indirect mechanism? Indirect mechanism can be, patient can have lateral compression. Yeah, so pelvic is compressed laterally on the sides, or patient can have anterior posterior compression. So anterior posterior compression or lateral compression is a form of indirect mechanism of trauma. Yeah. So so when patient has a lateral compression, yeah, so that means what happened? Patient pelvis is compressed on both sides laterally. Fracture can happen in this angle, yeah, or vice versa. When patient has anterior or posterior compression, patient can have fracture on the sides. Understood? Any questions on the indirect mechanism of trauma? Any questions? Do you have any questions? No. So as you know the mechanism of trauma, very important. So if you know the mechanism of trauma, we can try to think where the problem would have happened. You understand? So we can try to analyze where patient, what bone could have been damaged. We can think. Next condition, we'll little bit go forward. We'll little bit go back. We have to tell, is it a stable fracture of pelvis or unstable fracture of pelvis? So this is one more factor, very important to know, because our treatment entirely differs on this fundamental basis. So we know this is pelvic ring, yeah. So you know pelvic ring, yes or no? Hello, everybody knows pelvic ring, yeah. So this is a pelvic ring, yeah. So this pelvic ring separates what happened? Greater pelvis from the lesser pelvis, yeah. So fractures, if the fracture is not going to affect the pelvic ring, we call it a stable fracture. If fracture is going to affect the pelvic ring, then we call it as unstable fracture. Any question at this point? Do you have any questions?
No.
No, thank you. So we differentiated what is stable from what is unstable. So let's try to talk some example. Patient came to hospital with fracture of iliac crest. Stable or unstable fracture?
Stable.
Stable, yeah. Patient came to hospital, for an example, he had a blow on the anterior surface, fracture of inferior pubic ramus. Stable or unstable? Hello? Please, you can make wrong answer, no problem. Nobody's going to give you marks. Stable, yeah. One more patient came to hospital. Now he has fracture of both inferior pubic ramus? Stable or unstable?
Unstable.
No, still stable. Yeah, see, superior pubic ramus is holding it. Yeah, still it is stable in this condition. Now, patient came to hospital with fracture of superior pubic ramus. What do you think?
Unstable.
Unstable.
Very good. You thought unstable. Yeah, but you see, he has fracture of superior pubic ramus. Yeah, but still, what happened? Stability is maintained. You see, the workload goes somewhere here. Still, it is considered as stable. Pelvic is still stable. But if patient came to hospital with fracture of superior and inferior pubic ramus like this, what do you think?
Unstable.
Unstable.
Unstable, yeah. So if it happens, actually, what happened? Your pelvis is going to open like a book, actually. Yes or no? If it's going to be a fracture here, yeah, it's going to open like a book. Or if it happens on the other side, once again, it is going to open like a book, actually. Or if patient had a rupture of pubic symphysis, once again, it's going to open like a book. These are all unstable pelvic fracture. Understood? Hello?
Yes.
So we know what is stable fracture. We know what is unstable fracture. There is one more classification for unstable fracture. These unstable fractures are classified into two groups. There can be vertical instability or horizontal instability. What is vertical instability? So fracture happened, for an example, any of the fracture that we draw here. Yeah. So let's try to remove this, all these crazy things. Yeah. So fracture happened, for an example, here, and what happened? Damage to sacroiliosacral joint, yeah, posteriorly. So what will happen? Patient pelvic can move, yes or no? Vertically, yes or no? Yes, this is vertical instability. Next, one more scenario can happen. Yeah, patient can have fracture in this aspect, and patient pelvic can turn horizontally, or it will open like a book. Yeah, it is called as what? Horizontal instability. Understood? Hello. Simple thing is what happened? Fracture happened like this. Pelvic opened like a book. It is a horizontal instability. Understood? Hello.
Yes. Yes, sir.
So this thing you should think and you should put it into your head. So we discussed about mechanism of injury. In mechanism of injury, we discussed how it can happen. Yeah. So direct mechanism, three groups we told. Yeah. Direct mechanism, three groups: blow from the front, back, and side. Next, indirect mechanism. Yeah. We discussed two types: anterior posterior and lateral compression. Yeah, we discussed two. Now second branch of understanding this fracture is stable or unstable. Stable, it is clear. Unstable, it is divided further. It can be vertical instability or horizontal instability. Any questions?
No, sir.
No. Okay. So let's continue to the next step. Yeah. So next thing. So let's try to clear this thing and let's continue. Next, one more thing can happen is fracture of acetabulum. This is a different. This is entirely different condition. Yeah. As time permits, I will touch a little bit on this thing. Yeah. So fracture of acetabulum. So one more structure is acetabulum can fracture. So when there is fracture of acetabulum, it can be a complete fracture or incomplete fracture. So fracture of acetabulum can accompany with displacement or without any displacement. So sometimes when there is fracture of acetabulum, head of the femur can dislocate centrally. So we will discuss whether the head of the femur centrally dislocated or not dislocated. Understood? So this is, if you take fracture of acetabulum, we should try to orientate in this one. It's a complete or incomplete fracture with displacement or without displacement. Got dislocation of head of the femur or not. So this is to understand about what happened. Fracture of acetabulum. So after knowing this major classification, now let's come to clinics. So let's try to refer once again, think about the general signs and specific signs. Of course, the patient will have all general signs. There will be pain present, swelling present in the region, bruise can be present, yeah, increased local temperature, loss of function. All general signs will be present in the pelvic region. But what can be specific? The specific signs can be, there can be pathological mobility. I will tell you how to check this pathological mobility, and we might check crepitus. Maybe sometimes in open fracture, maybe what happened, we can see appearance of bony fragment, and what happened, the pelvis can look deformed. So in this we can see four of the signs. So we can see pathological mobility, crepitus, appearance of bony fragment, and deformity. Yeah, we can see all these 4 sign. So in order for us to check pathological mobility or crepitus, we have to do some maneuvers, yes or no? So when we try to do this maneuvers, it is very painful. It will be traumatic to the patient. Yeah, so we should think this thing into consideration. There is a sign called as Larry and Verneuil sign, so where we try to open the book, like we put hand on the iliac crest, yeah, and we try to open the book or we try to close the book, Verneuil, yeah. So Larry sign and Verneuil signs can be checked. Next, one more manipulation. This manipulation to talk about vertical instability. So one doctor put the hand on the patient hip, another doctor, what happened? Vertically, we try to pull and what happened? Lift up push the leg, yeah, vertically, yeah. So if there is vertical displacement, the doctor who is holding it, he will feel what happened? Pelvic is getting displaced vertically. Larry and Verneuil sign is there to check whether there is horizontal instability present or not. Understood? That is opening the book or closing the book. That is, we put the hand, like exactly how the doctor puts the hand on the pelvis. We try to open the pelvis. We try to do abduction type of movement. Another one is we try to close the book. Yeah, if it is going to trigger pain, we think about fracture. Normally, what happens? We can't open the pelvis or close the pelvis, and there won't be any pain. Next sign. This is very simple sign here. So you know, xiphoid process. We draw a line from xiphoid process we put measuring tape from xiphoid process to anterior superior iliac spine, and we measure this length. It should be in normal equal, but in case of a fracture with displacement, yeah, unstable pelvic fracture, this length is going to change. Understood?
Yes,
Understood,
doctor.
doctors. In this area, any questions to me? In this area, do you have any questions?
No, doctor.
No questions, yeah? Okay, so of course, yeah. So of course, what we can do also, we can stand and we can also think about what happened. You can think about iliac crest and patient standing. Yeah, in normal, what happened? Iliac crest. If you imagine iliac crest is here and here. Yeah, if you draw a line, what happened? When patient is standing, it should be the same level. Yeah, they should not go up or go down. Yeah. So if it is going to get tilted. If it is going to be tilted little bit, anterior iliac spine, if it is going to get tilted, one reason can be what happened. One of the physiological reason can be what happened. This limb can be, if it went like this, yeah, this limb can be shorter than this limb. So when this limb is shorter than this limb, of course there is going to be a tilt like this. This is reason, yeah. Here the length of the limb can be shortened because of different factor, yeah. Maybe it is by birth some defect, yeah, or maybe because of fracture of the lower limb also can give this thing, yeah. But in pelvic fracture, yeah, when these signs are positive and the tilt is present, of course, here the tilt happened because of what? Fracture with displacement or unstable pelvic fracture. Understood so far?
Yes.
Okay, great. So now with clinical signs, approximately we can come to conclusion that this patient has fracture, if you can understand the clinics. So we take X-ray, yeah, to confirm our diagnosis that patient for sure has pelvic fracture. So here we can see here different projections here in which what happened, we can see the pelvis or we want to see the pubic bones, you understand. So here, so let's try to refresh our knowledge. Yeah, so what is the structure that is being discussed over here? What is the structure that is drawn here? What is the structure? What we see here? What is this? Just now you told me before in the bone.
Wing of
Iliac
skin.
fossa.
Iliac fossa, or here in
Iliac
general,
wing.
we don't, it's a wing of the iliac bone. Yeah, we are checking how is the wing of the iliac bone. Yeah, is it normal or there is fracture? Yeah. Next, here we can see here. Yeah, how do you call this?
Superior ramus.
Superior ramus. This one.
Inferior ramus.
How do you call this? How do you call that? It's a foramen. Yeah. How do you call that foramen?
Obturator.
Very good. This is obturator foramen. Understand, doctor? Of course, yeah. So you know actually, yeah. So here we have ischial tuberosity, ischial bone, yeah. So here we have acetabulum, yeah. So I'm sorry, yeah, I'm not artist, I'm just drawing with my mouse, it is hard to draw. Acetabulum, head of the femur is present, neck of the femur is present, greater and lesser trochanter goes already, yeah. So here we have sacrum, here we have coccyx, sorry, a little bit went on the side. So here we have coccyx, yeah, the bone present over here, yeah. So we can try to differentiate. Yes or no? Any questions on looking at the bone and trying to tell where the fracture? So if you know how the bone looks like in normal, in X-ray, it won't be any hard for you to look fracture present or not. Understand? So you should look at a normal, and you should differentiate. So now comes how to do first medical aid for the patient. See, first medical aid is done on the road. Yeah, that is even before you take the X-ray, we will do first medical aid on the road. So what to do? See, for pelvic fracture, we only have posture. Understand, doctor? So first we'll give analgesics to the patient. Yeah. So mainly we'll give non-narcotic analgesics. If there is any closed injury to abdominal cavity, or if there is damage to patient's unconscious, no narcotic, you will directly give non-narcotic analgesics to the patient, like analgin, baralgin, intramuscularly 1 to 2 ml. After that, we put patient in the posture. What is this posture? This posture is called as Volkovich posture. So ankle joint is together. Patient is in supine position in a hard stretcher. Ankle joint is together. Knee joints, patient hip joint is flexed. Patient hip joint is flexed slightly and abducted. You understand? So if you look if you look straight, if this is patient hip joint, patient lower limb, it goes like this. Understood? Patient lower limb will be going like this. Understand? So and then the booster, yeah. The booster is here in this region. Understood? Hello? Understood? Understood, doctor. So,
Yes, doctor.
so what is happening in the lateral view? We can see the hip joint is flexed. We can see it is flexed, of course, yeah. And what happened? Abducted. ABD, abducted. It is abducted. Hip joint is abducted. Understood? Ankle joints are together. So you can try at home, yeah, in your bed when you lie down, put a pillow or any booster under your knee joint, yeah, tie your ankles together, yeah. And what happened? Not ankle joint should be together and knee joint should be apart, but your hip joint should be flexed. In this joint, in this position, what happened? Muscles of your hip region is maximally relaxed. Understood? And we transport the patient to the hospital. Any question? Any questions?
No.
Any questions, doctor?
No.
So, what I wanted, where is the marker? So, this posture, this Volkovich posture, frog posture, is not only, it is not only used as a temporary immobilization. If patient had a stable fracture, patient is going to be even in the hospital for treatment in this posture. Understood? So this posture is a very important posture, Volkovich posture, not just for temporary immobilization, but even in the hospital. If patient has a stable fracture, he is going to be treated only in this posture. So try to write this thing. Yeah, this is specificity. So today you learned a new posture for new posture and new that is for first aid and new method for treatment. So next comes its complication. Yeah. So how to diagnose that this patient has patient is developing shock or not? How to diagnose this patient develops shock or not? How do you diagnose them? How to diagnose it? Yeah, pelvic fracture, but how to diagnose the patient is developing shock or not?
The patient has anuria.
Huh?
Anuria.
But you have to wait. You have to wait. How do you know in half an hour patient? Because we have only 20 minutes, yeah, 15 minutes from the site to the hospital, maybe 1 hour. Yeah, in this 1 hour time, we can't tell patient has anuria. You understand? And we can't put shock.
Patient has low BP and tachycardia.
Very good. One parameter is what happened: drop in blood pressure and increase in pulse. Understand, doctor? So we have drop in blood pressure and it is compensated by what? Tachycardia. Yeah. So increase in pulse. So we know this thing by what? Algover index. Yeah. Shock index. Yeah. When systolic blood pressure by what happened? Heart pulse. Yeah. We try to divide and we should know that it should be less than 0.8. Yeah, if you want to talk about no shock. But here patient develops shock. So when patient blood pressure is dropping, yeah, and increasing heart rate, what you will do to the patient? So what is the anti-shock measure we give to the patient? Patient is having unstable hemodynamics. So what you will do to the patient first?
Infusion therapy.
IV.
So we start to canal, we put what? IV canalization, yeah, and what happened? We start our infusion therapy. Yes or no? Yes or no?
Yes, sir.
So when we start our infusion therapy, what should happen to our patient?
BP should normalize.
BP should from low BP, it should normalize. Pulse from trachea should stabilize. Is that no? This is what happened. This means what happened? We are successful in handling the shock. But what happened in our scenario? What will happen in pelvic fracture? Sometimes what happened? It is not stabilizing. Once again, what happened? Blood pressure is dropping and pulses keep on increasing. It is not stabilizing. What hint does it give it to you? What hint does it give you?
Internal bleeding.
So patient has what? Internal bleeding. Yeah. So patient has here intra-abdominal, in the sense intra-pelvic bleeding. In our case, concrete case, this patient is having. Yeah. So we put a very big question mark and we have to think how to handle it. How to stop this bleeding? What do you think? How do you think to stop this bleeding? Hello? How to stop the bleeding? What do you think? Any idea? How to stop the intrapelvic bleeding? Any idea? Upper limb, lower limb, you know, you apply tourniquet, but what to do? Any idea? Anyone? No one. So one of the things that can help us to save the save the valuable life of a patient is this suit. It is called pneumatic anti-shock garment, PASG. A pneumatic anti-shock garment or suit. Yeah. So what does it do? So it is same like it is inflatable suit. When you apply the suit and you inflate it with air. Yeah. When you inflate it, it will compress the abdominal aorta, in which it will increase only centralized circulation. Understood, doctors? Hello.
Yes, sir.
Everybody
Yes, sir.
understood. So one thing is what happened. So we compress abdominal aorta. Here what happened? We maintain circulation to the vitals and we should transport the patient as soon as possible, yeah, and continue infusion therapy. So this is what we can maximum do to the patient to save the patient's life. First aid, any questions? Any questions in first aid? Hello?
No, sir.
No, sir.
So now we come to treatment. Yeah, first aid is clear. So now we come to treatment. Complication will come in few minutes time. So now we come to treatment. So treatment can be divided into two groups. You already know. Yeah, treatment can be what? Conservative or operative. Yes or no? Hello?
Yes.
Yes. So how to treat this patient conservatively? Yeah. So here we can see a patient. Yeah. Here you see an X-ray is given. Yeah. See, this is a sternum of this patient. This is head of the femur of this patient. This is neck. Yeah. Greater trochanter is present. Lesser trochanter is present. Yeah. So everything in relationship to everything in relationship to femur in this place is normal. But let's go to here. Is it normal? What do you think? Is it normal or not normal? What do you think in this region? Is it normal?
No.
Look here, yeah. How is acetabulum? See here, patient has what? Acetabulum fraction. Head of the femur went in already central. You see superior pubic ramus, inferior pubic ramus, pubic body. Yeah, you see what happened here already. Yeah, messed up actually. Yeah. So there is fracture of acetabulum, central dislocation. There is fracture of the ramus also happened. Yeah, and patient a little bit. What happened? Has an unstable pelvic fracture in this scenario actually. Yeah. So here we have one scenario. Next, Here, once again, we have one more scenario. What happened in this scenario? In this scenario, what happened? We can see pubic symphysis, the space between the pubic symphysis, yeah. You know in normal how it should be, yeah. From here and here, it's not such a big space, yeah. It already opened like a book and separated actually, yeah. So here we have once again horizontal instability fracture. Once again we have, yeah. There previous one may be vertical instability. So these fractures are indicated for what type of treatment. If you have unstable fracture, how to treat them? You have to treat them only operatively, yes or no? Yes? Hello?
Yes.
We discussed already, stable fracture is treated conservatively. Yeah? Unstable fracture should be treated operatively. But maybe because of some systemic condition, there is contraindication for surgery. Understand? So what to do with this patient with this unstable pelvic fracture? We have to treat them conservatively only. Yeah? So how to treat them conservatively? So here we can see some scenarios. Yeah. One of the scenarios, what happen? You put patient in this hammock. Yeah. So this hammock will help to what? Close the book. So it will turn like this. And you turn like this. Yeah, with this, what happened? We are closing the book, and this hammock removes the horizontal instability that is present in this concrete patient. This is one. This patient is indicated for operative method of treatment, but contraindicated because of different systemic conditions. So he is treated conservatively. Here in this scenario, we can see patient is once again indicated for surgery. Maybe while we are preparing for surgery, or we plan to treat conservatively only. In this case, what happened? We can put patient on what? Skeletal traction, skeletal extension. Understood? Hello? The third method of conservative method of treatment, this is only for stable fracture. If patient had a stable fracture, patient will continue to be in Walkovich posture. Patient will come to hospital, yeah, he'll be in Walkovich posture and he'll be treated in Walkovich posture. Average time for consultation, it depends, stable or unstable fracture. If it's going to be stable fracture, in 6 to 8 weeks time, everything is going to be fine. If it is going to be an unstable fracture, it can go from duration, can go from 8 to 12 weeks, and it can go from half a year to more. Understand, doctor? So depending upon how unstable the fracture is. So I gave you 3 conservative method of treatment. 1 in case of stable fracture, 2 in case of what? Unstable fractures. Next. And let's think about unstable fracture. So here we can have, once again, we can see we exercise a little bit bad here. Once again, we see what happened. You see acetabulum, how it should be, head of the femur, how it is here over here. Yeah, then we can see head of the femur. Yeah, but here what happened? We see, you see what happened, how integrate, how the acetabulum is together. Here what happened? Acetabulum fracture. You can see fracture happened to the acetabulum, broke already. And what happened? Head is already coming to the center. Fracture of here there is a fracture, and we can see what happened. This part of the pelvis went up when compared with this one actually. So here we can see unstable pelvic fracture with vertical instability. Yeah, fracture of one side. What happened? We have fracture with dislocation. Here we have fracture of superior pubic ramus on both sides. Yeah, so here this is a very complicated pelvic fracture. So here in this scenario, yeah, once again, how to treat? Treatment is what? Operative method of treatment. Yeah, so what we do here in this concrete patient, treated with the help of external fixator. So here we can see patient is on X-ray, post-operative X-ray. We stabilize the pelvis. Yeah, you can see already. Yeah, vertical instability is displaced. Bone is pelvis approximately brought to normal play position. Yeah, head of the femur you can see already. Still fracture is present. Yeah, displacement is present, but you can see actually almost bone is being put in normal position. Yeah, so here we can see a scenario how the patient is going to be in real life. Yeah, so of course, yeah, you can see, yeah, pelvic fracture, it is a comics, but this is the reality of a patient with pelvic fracture. Yeah, so they will be on an external fixator for a very long duration. So they will segment work. Sometimes treatment can last from 6 months, even 1 year, until 2 years, until what happened, they completely have a normal pelvis. So if it is going to be simply fracture of superior pubic ramus, then we can go for reconstruction plates and screws, or only with plates and screws, or simple plates and screws, or screws. Understood? Hello?
Yes. Yes, doctor.
So with this, we finished. What did we finish? We finished how to treat fractures of pelvis, yeah, without any complications. So now let's think about what complications can happen. So we already discussed in the beginning of the lecture. So complications can be shock development. I told you how to handle the shock actually. Yeah? So it is a protocol that you have to follow actually. Apart from this, what can be damaged? So patient can have what if at the time of trauma, if the urinary bladder was full, heat to the pubic bone will damage what happened your urinary bladder, and patient can have what either intraperitoneal damage or retroperitoneal damage of the bladder. So urinary bladder can be damaged. Next, what can be damaged in male patient? What happened in male patient? Maybe urethra can be damaged. So these two complications, this is in relationship to the urinary bladder. Yeah. So how to diagnose urinary bladder damage? Yeah, if urinary bladder damage, so there is no contraindication for what insertion of urinary catheter. Yeah, you insert urinary catheter and you insert physiological solution, 200 ml of what any physiological solution like normal saline. If you can aspirate all back, there is no damage. If you insert 200, only got 50 ml back. That means it's a intraperitoneal damage to the bladder. You insert and you got 150 ml back, then it can be a retroperitoneal rupture of the urinary bladder. Yeah. Plus, what happened as a golden protocol? Any pelvic injury, for sure you should do what ultrasound. Once again, you find fluid. Yeah. You can do laparosynthesis. What is this fluid? Right? Analyze. Yeah, you can differentiate the blood, or by laparosynthesis you can differentiate the blood or urine. Yeah, and it is already indication for what diagnostic laparoscopy. If it is a bleeding, you'll try to find the source of bleeding and try to stop. Yeah. Here, if it is going to be urethral damage, what can happen? Patient will have what feel to urinate, but he cannot urinate. Maybe patient has hematuria can be present here. And ultrasound, what happened? Urinary bladder is full and he cannot urinate actually. Yeah. So in this case, what happened? Indication. Indication is what? Indication to put cystostomy in the patient. So in both the case, what happens? Cystostomy will be an indication to exclude this condition. Next, if patient has injury to female reproductive organ, once again here the bleeding is going to be very mass. And if bleeding cannot be stopped, maybe it can be an indication for emergency hysterectomy. So when we talk about injury to large intestine like sigmoid colon or rectum, yeah, it is indication to put what happened? Colonostomy. Understand, doctor? So when patient has this complication, injury to internal organ, our job is to stabilize the pelvis, and what happened? Patient will be a main patient for either urology, gynecology, or general surgery. Yes, they will be in this ward, and we will be a consulting doctor. Yeah, our job is to stabilize the pelvis. Yeah, with an external fixator, and concretely what intra-abdominal condition is developed. Yeah, concretely that will be the first life-threatening condition that will be handled. Any questions so far on this?
No, sir.
No. No. So let's
No, sir.
continue. Let's continue. See, when we talked about this, when we talked about acetabulum fracture, we went there to discuss one more component of acetabulum fracture is dislocation of femur. Dislocation of femur is a very serious condition. What will happen in case of dislocation of femur? Yeah. So let's try to let me see. So let's go back with this picture. So let's try to draw. Yeah. So here we have acetabulum. Imagine this is the acetabulum and this is the head of the femur. Forget about the fracture. Okay. We are not going to talk about fracture of neck of the femur. So here this is the this is acetabulum, the red color one, and imagine, let's see, this is the capsule of the joint. Capsule of the joint will connect acetabulum with this region. Understand, doctor? So here in the femur, we'll have intertrochanteric line and crest. The capsule of the joint is going to run like this, and you know, actually inside the joint, we'll have what? Our fluid. Yeah. So here we have our fluid actually. See, when we take hip joint is a very interesting joint. So here schematically it talks about what happened, how the head of the femur is getting nourishment. Yeah. So here we have fovea centralis, yeah, little bit ligamentum teres, a very small ligament. From there, little bit of artery comes and little bit of nourish. This blood supply is not very big. Mainly the blood supply comes from the deep femoral artery, which is giving branch like medial and lateral circumflex femoral artery. Yeah, this is the biggest branch of the artery. This artery is going to be, this artery is exactly on the capsule of the joint. This is the capsule of the joint. This artery is going to lie on the capsule of the joint, and blood supply will go from distal to proximal. So when patient has dislocation of the joint, patient will have rupture of capsule. Yeah, when there is rupture of capsule, these blood vessels can be ruptured, and what happened? Head of the femur will lack in the blood supply. One more reason why this is a big problem is normally if you take any bone is surrounded by periosteum. So periosteum is a layer that surrounds the bone, yeah, that is surrounding the bone. The periosteum is very rich in blood supply through which the artery goes in. But in our femur, we have a neck. So here this is a neck of the femur. Here this is a neck of the femur. The neck of the femur become intra-articular. So normally what happens in any joint, this periosteum will continue. This periosteum will continue actually until the head in any bone. It should continue until the head in any bone. But unfortunately, in hip joint, head of the femur, head and neck both become intra-articular, so periosteum exactly stops here. So we don't have any periosteum. So solely the blood supply that is running from distal to proximal is the one that is supplying blood supply. So when there is a fracture or dislocation, yeah, blood supply to the head of the femur is lost. So it leads to a condition called as avascular necrosis of femoral head. What is it? What is the condition? Avascular necrosis of femoral head. This is a condition that develops very late. So we should try to think about this condition. Yeah, that is that one we should think. See, when we talk about dislocation of acetabulum, yeah, so dislocation of hip joint, yeah, there are 5 dislocation. The hip joint can dislocate posteriorly or anteriorly. Hip can dislocate either posteriorly or anteriorly. If it is going to go posteriorly, they have 2 variants, posterior superior or it can be posterior inferior. In the same way, anteriorly it can have anterior superior or anterior inferior. So when you come to the department, please, you can ask the teacher, yeah? So you can see these names, how to remember their names. So simple. In the posterior superior head of the femur is going to lie on the iliac bone, so only it is called iliac. When we talk about posterior inferior, it is going to be the sciatic bone, so it is called sciatic. When it comes to anterior superior, head is going to be on the pubic bone, so only it is called pubic. When it comes to anterior inferior pubic, it's going to be in the obturator foramen, so only it is called obturator. So simple, either you remember by localization of head of the femur or simple term. So as you studied in the different dislocations, yeah, so it can go anteriorly or posteriorly. If it is going to go anteriorly, that can anterior superior and anterior inferior. Posterior, that can posterior superior or posterior inferior. Yeah. And today our talk of the topic is central dislocation that happens when there is fracture of acetabulum. Head of the femur will go centrally. Yeah, this is the characteristic thing that we want to discuss. Why I'm discussing this topic. Next, how to find the clinical picture. Here, clinical picture is very well explained in this picture only. I'm not going to go anywhere further. See, if patient has posterior dislocation, the limb is going to be internally rotated. So remember, somehow posterior means there is internal rotation. Remember this one. If it is going to be anterior dislocation, it is going to be opposite. The limb is going to be externally rotated. However you want to remember, try to remember them. Yeah. So what is happening in posterior superior dislocation? There is slight flexion in the hip, slight flexion in the knee, and internally rotated. But if it is going to be inferior, there is more flexion in the hip, more flexion in the knee. And once again, what happened? Limb is internally rotated or limb is abducted. There is adduction. Limb is adducted, going towards the body is happening. But when we come to anterior dislocation, you see little bit of flexion in the hip and knee. But what happens? Limb is externally rotated. This is the key point. This is the key point. Same scenario will happen. When it is going to be here in the anterior inferior. So here we see more flexion in the hip, more flexion in the knee, and once again what happened? The limb is externally rotated and abducted. ABD. We can see abduction. So this is the clinics of this dislocation. When patient has dislocation, patient concretely come to hospital with these positions. Any questions on this position? Hello.
No.
Next thing. that we should see, that we can see, already central dislocation. When there is fracture of acetabulum, here we have central dislocation. One more thing can happen in posterior superior dislocation is fracture of roof of the acetabulum, and the hip head of the femur is going to go back. Understand, doctor? When there is posterior superior dislocation, there can be damage to the roof of the acetabulum. This can happen. One more clinical significance that you should know is from when there is posterior superior dislocation, this head of the femur can damage the sciatic nerve. It will go damage the sciatic nerve. So patient can have what? Paralysis along the projection of the sciatic nerve. So posterior aspect, and maybe patient even can have drop foot also patient can have. Yeah. So posterior superior dislocation complication is what happened? Damage to sciatic nerve. So in outline, I gave you what can happen in case of dislocation. Apart from this sign, of course, you should know the signs of dislocation. Yeah, we discussed in the first and second lecture. Yeah, all general sign is present. Apart from this typical position of the limb, patient will have a springing resistance to any movement. You try to make any movement, he will not let this movement happen. First aid in case of any of this above situation is what happens. You give analgesics without changing the position. You immobilize using cramer spleen posteriorly, yeah, from the shoulder joint until tip of the toe, yeah. Posteriorly apply the cramer spleen and transport the patient to the hospital. Now patient came to the hospital. Yeah. One more thing, one more interesting sign is Rosen-Ellerton line. You draw a line from anterior iliac spine discal tuberosity. Graded trochanter will be on this line. Yeah. In case of dislocation, graded trochanter is not going to be in this line. This is one more authentic sign called as Rosen-Ellerton line. See, here we have an X-ray film. Let's try to see here. Yeah, so this is acetabulum in our patient. Yeah, and this is head of the femur. Yeah, so everything is fine in this thing. Is it a normal X-ray? This X-ray or not normal X-ray? What do you think? We are talking about this.
Abnormal.
We are talking about this X-ray. Sorry, we are talking about this. Normal or not normal? What do you think?
Not normal.
It is not normal. Yeah. So what condition we have? So in this side everything is fine. Everything is fine. But this side what happened? We have what you see acetabulum, how it was here. Yeah. So there is fracture of acetabulum happened here and head went centrally. Yes or no? Plus what happened? Fracture of what? Superior pubic ramus present here. Yes or no? Hello?
Yes, doctor.
Yes.
So here we have what dislocation we have? What dislocation is present in this patient?
Central.
So here we have central dislocation in our patient. Very good. Next. So let's come to this. Let's come to this hip joint. What pathology we have in this joint? Is it normal or not normal?
Not normal.
Not normal. See, this is acetabulum. This is head of the femur. Yeah. So what happened over here?
There is posterior superior dislocation.
Very good. Yeah. So we know. See, this acetabulum head is above. Yeah. So we know it is superior. So everything is superior. Yeah. But why did you say it is posterior superior? There are two variants. Superior, agreed. Yeah. Because head is above this is head and it is above the acetabulum. Sure, it is superior. But why? How to differentiate? Is anterior superior or posterior superior in the X-ray? Two methods to
Because
orient
it's
it.
on the iliac.
Very good. Yeah, very good. So this is the iliac bone. Of course, this is iliac. Yeah, iliac is posterior superior. Yeah, we know already. Yeah. Another thing, another way to tell is how is this the midpoint of the bone and how is this bone? Here we see the bone is what? Adducted. Yes or no? Adduction is happening. It is towards the body. Yes or no? Hello? Yes or no?
Yes, sir.
So we see the limb is what? Limb is adducted. Yeah, limb is more towards the body. Adduction. Yeah. So of course, internal rotation adduction is for posterior dislocation. This is another sign to differentiate. Understand? So hallmark sign is it is the head of it is on the pelvic bone. Of course, clear with this dislocation. Clear?
Yes, doctor.
Everybody understood?
Yes.
Yes,
Yes,
sir.
Very
sir.
good. So now let's come to this X-ray. What do you think about this X-ray? So here we have acetabulum. So of course you know actually, yeah. This is head of the femur. So what happened to this dislocation? What is this dislocation? What is this dislocation, doctor? What do you think?
Anterior, inferior.
No, very good. Yeah, so it is anterior inferior. Yeah, okay. Yeah. So why do you say it is? So we know it is inferior. Yeah, acetabulum is here and it is below. Yeah, so we know it already went down. Inferior, understand. But how do you differentiate? Is anterior inferior or posterior inferior? How to differentiate?
It's in the obturator foramen.
Of course, if the head is inside the obturator foramen, in this case, it is in the obturator foramen. Yeah. But another point is what happened. Once again, you see the midpoint and see the limb. How is the limb when compared to the midpoint? It went away, yes or no? Here there is what? Abduction. Yeah. So we know abduction and external rotation is characteristic for what? Anterior dislocation. Yes or no? Hello? Understood? Hello?
Yes.
So let's see. So this is actually a anterior inferior. Yeah. This one, how do you think about this one? This is not a pure AP view, little bit. It has a posterior view. It's angulated view. So what do you think about this dislocation?
Posterior, superior.
So once again, this is posterior superior. Yeah, understood. This is acetabulum. Head is above the acetabulum. Yeah, so we know it is actually superior. Yeah, it is in the iliac bone. Little bit angle. The X-ray was taken from the little bit of lateral angulation. Yeah. But how do you know for sure it is posterior midpoint? And we try to draw a line. Yeah, of course, you see what happened. The limb is what happened. Adducted. Yes or no? The limb is going towards the body and internally rotated. Understood? Hello?
Yes. Yeah.
So I hope you all understood this concept. Yes. So by now you differentiate dislocations. Yeah. You know the clinics of dislocation actually. Yeah. So treatment. How to think about treatment? See, hip joint once again is a very strong joint. Yeah. In the hip joint we have a very strong muscles. In order for you to reduce the hip joint, it can